So pharmacodynamics means what the drug does to the body. So at the end of today's lecture, you will be able to understand what pharmacodynamics is, what are the sides of drug action, then how the drug interacts with the receptors or its mechanism of action, and how the receptors they are going to produce the intracellular or the extracellular changes or the actions through which we are going to get the effect of the drug. So this will be continued in tomorrow's lecture also. So in Greek, pharmakon means drug and dynamics means action or the power. So pharmacodynamics will include all the aspects relating to what a drug is going to do to the body. So it includes the mechanism of action and the effect which the drug is going to produce. So if we see the pharmacokinetic profile of a drug, so after the absorption, the drug gets distributed and then metabolized and excreted. So the pharmacodynamics is going to take place somewhere in between the distribution and the metabolism. So most of the drug, after distribution, they reach to the site where they have to produce the effect, and there they are going to produce the effect, and after that they get metabolized and excreted. Some of the drugs they get activated during the metabolism also, they produce the effect, and then they are excreted from the body. So one is action, other is the effect. Action is how and where the effect is produced, and effect is the type of response produced by the drug. That means action is how, what is the mechanism of action, and then effect is what is the response which we are going to see with the use of a drug. So the sites of action of a drug can be extracellular, cellular, or the intracellular level. So anywhere, different drugs they have their site of action at various different locations of the cell. So the sites can be of action of a drug can be a receptor. So the different types of receptor are G protein coupled receptors, the kinase linked or the enzyme linked receptors, then the nuclear receptors which are present inside the nucleus, and then the ionotropic receptors where the receptors they are bound to certain ion channels. The other type of site where the drug action can be through the directly through the ion channels, either voltage gated or the ligand gated ion channels. There the drug can bind and produce the effect. The third is the carrier or the transporters. The drug can modify the different types of transporters and then can produce the effect. Or due to the virtue of the physical or the chemical property of the drug is going to produce the effect. Examples of the transporters like norepinephrine transporter, dopamine transporter, serotonergic transporter. So modifying these transporters, the drug can produce the effect. Or due to its physical or the chemical properties such as charcoal as an absorbent, chelators due to their chemical reactions, they are going to produce the effect. The other side of fourth side is the through the enzymes. So the drugs can act by increasing the level of enzyme or decreasing the level of the enzyme, such as drugs act, such as acetylcholine esterase. The drugs can act as an acetylcholine esterase inhibitors or the cyclooxygenase inhibitors such as aspirin. So these drugs are going to produce their effect by modifying certain enzymes, either by inhibiting or increasing their level. So these are the different sites, four major sites where a drug acts and produces the effect. So what type of action can a drug produce? So drug can produce basically stimulation, inhibition or depression, or replacement, or irritation, or cytotoxic. These are the different types of response which a drug can produce. By stimulation, I mean to say that some drug act by increasing the activity of a specialized cell. The example is adrenaline stimulates the heart and thereby it increases the heart rate and the force of contraction of the heart. So adrenaline is a stimulant drug for heart. Similarly, in a different context, inhibitors are those drugs which decreases the activity of the specialized cells, like alcohol, barbiturates, general anesthetic. These drugs, what they do, they depress the central nervous system and thereby producing the sedation and the sedation. And atropine inhibits the acetylcholine action. So these drugs are inhibitors. Then the drug can act as a replacement when there is a deficiency of an endogenous substance. So these drugs can replace the endogenous substance. Like we give exogenously insulin in patients of diabetes mellitus, or we give thyroxine in patients of cretinism or mixed edema, where there is deficiency of thyroid hormone. So replace a drug can act as a physiological replacement of endogenous substances. Then the drug can produce irritation. Certain drugs, when they are applied topically, they cause irritation of the skin and the adjacent tissues. And based on this principle, counter irritant drugs are made. What these counter irritants do, they irritate the topical surface, and thereby they obscure the deep pain, and they help in uh, they have their effect as an analgesic, or they relieve the deep-seated visceral pain. So these drugs are counter irritant drugs. Examples are the eucalyptus oil, methyl salicylate, and these drugs they are basically used in deep-seated pain such as sprains, joint pain, myalgia, etc. Next is the cytotoxic drugs. So these drugs are used for the treatment of infectious disease which are caused by bacteria, the cancer, and these drugs are they are selectively toxic for the infecting organism and the cancer cells. And examples are the anti-cancer and all the antimicrobial agents. So these drugs they are particularly effective against these cancer cells or the bacteria, and they are not harmful for the host cells. So coming to the mechanism of action of the drug, so the drug can produce its action by either by a receptor mediated or a non-receptor mediated, or by directly targeting the specific genetic changes, and by producing its and that is how these drugs are going to produce the effect. So majority of drugs act either by receptor mediated or the non-receptor mediated actions. A part of this, there are drugs uh, which can produce their effect based on their chemical actions, or the chemical actions, or the physical actions, or other mode. Not necessarily every drug acts through a receptor or non-receptor mediated. For example, bulk laxative like isabgol. You all must have heard about this isabgol, that because of its osmotic action, it imbibes water and thereby helps in the clearing of the stool in patients of constipation. So it is the physical property of this drug, this bulk laxative, they are going to produce the effect. Similarly, activated charcoal, when they are given in cases of poisoning, what they do, they because of their adsorptive property, they imbibe the poison, and then they are vomited out. So that is how this activated charcoal helps in removing the undigested poison from the body. Similarly, because of the osmotic activity, mannitol, magnesium sulfate are used, and radioactive property, iodine and other radioisotopes are used. So these and antacid, they neutralizes the gastric HCl. So this is one of the chemical property of the antacid, that they neutralizes the gastric hydrochlorides. Similarly, because of the release of the nascent oxygen, potassium permanganate acts as an oxidizing agent. They oxidize the bacterial protoplasm and thereby kill the bacteria. Similarly, chelating agents are used in heavy metal poisoning. They have a cross-shaped structure. They form different type of coordinate bonds with the heavy metals, and thereby they decrease their absorption. They help in the removal of these heavy metals during their poisoning. Similarly, cholestyramine is used in hypercholesterolemia, where they help in the sequestration of bile acid and cholesterol in the gut. So they decrease the bile acids and thereby cholesterol in the body. Mesna is used as an antidote for due to the metabolites of cyclophosphamide. They scavenge the psychotoxic reactive metabolites of cyclophosphamide, and thereby they are going to prevent the toxicity to the bladder. So the coming to the different sites of action. So as I have told you, the drugs can act first at the enzyme, where A drug can act as a stimulator where it binds to the enzymatic site and helps in increasing the production of the end product. Or a drug can act as an inhibitor where the drug can bind to the enzyme and no product or the non-functional products are formed. So this is how different stimulators or the inhibitors can stimulate or inhibit certain enzymes, and they are going to produce modify the action of a certain enzymes. The drugs can act through various carrier or the transporters where the drug can act as an opener of certain ion channels. So the drug will bind to the ion channel, leading to the opening of the ion channel and influx of certain ions. The drug can act as a blocker of these ion channels, where it blocks these ion channels and the inflow of the ion is blocked. And that drug can also act as a modulator, whereby it modulates the activity of ion channels, thereby producing its effect as a modulator. The drug can act on the transporters where the drug binds to the transporter, inhibits the transporters, and thereby decreasing the transport of certain endogenous substances. And that is how norepinephrine transporter inhibitors or the serotonergic transporter inhibitors, they are going to act. And the last is the drug binding to the receptors. The drugs can act as they bind to the receptors, they are going to stimulate it, then the transducer mechanism produces the effect. So the drug can act as uh, a agonist, that means binding and increasing the receptor action. The drug can act as a competitive antagonist, whereby the drug binds to the same site as the agonist and thereby inhibits the receptors and then the effector also. Then the drug can also act as a non-competitive antagonist, where the site of binding of the antagonist is different from the agonist. It binds to certain other site, produces changes, conformational changes in the receptor, so that the agonists do not bind, and thereby they inhibit the transducer and the effector mechanism. So, for a receptor mediated action, one is the transducer and then the effector. Transducer is attached to the receptor. When a agonist bind to the receptor, it produces changes in the transducer, and this transducer then further produces changes in the effectors, and based on that, the response comes. That is how these enzymes are going to act. So, three things are important: one is receptor, transducer, then the effector. So coming first to the enzymes, so the enzymes they are competitive inhibitors of certain enzymes, endogenous enzymes, and thereby these drugs are going to act. Cholinesterase is the enzyme which metabolizes the acetylcholine when the acetylcholine is released from the cholinergic uh, uh, neurons, and this leads to a depletion of the acetylcholine effect. The acetylcholine is very quickly metabolized. So the competitive inhibitor drugs for cholinesterase is physostigmine and neostigmine. So what they do, they will inhibit this enzyme and they will increase the uh, life of acetylcholine. Thereby, this acetylcholine will become longer acting or will act for longer duration and more of the cholinergic effect will come. Similarly, monoamine oxidase is a metabolizer of enzyme which metabolizes catecholamines, that is the norepinephrine, epinephrine, and the dopamine. So, the competitive inhibitor is the moclobemide. So, it will inhibit this monoamine oxidase, so the lifespan of these catecholamines increases. Similarly, dopa decarboxylase metabolizes levodopa to dopamine. So when we give carbidopa with levodopa, what it does, carbidopa inhibits this enzyme and thereby increases the duration of or half-life of levodopa. Similarly, allopurinol inhibits the xanthine oxidase, which is going to produce uric acid from hypoxanthine. And so by inhibition of the synthesis of the uric acid, aripiprazole is used in patients of gout. Similarly, angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. The captopril, they are the inhibitor of this drug, angiotensin converting enzyme, thereby inhibit the synthesis of angiotensin 2, and they are used in hypertension. Similarly, finasteride, they inhibit the 5-alpha reductase enzyme, which converts testosterone into more active product, that is dihydrotestosterone, and thereby these drugs are used in prostatic hypertrophy. Aromatase inhibitors are the letrozole. They inhibit the conversion of testosterone into estrogen. And similarly, sulfadiazine, it is an antibiotic, and it inhibits the bacterial folate synthesis by inhibiting the conversion of PABA, that is para-aminobenzoic acid, into folic acid, thereby inhibiting the bacterial growth. And that is how they act as an antimicrobial agents. Then there are certain drugs which are non-competitive inhibitors, such as acetazolamide inhibits the carbonic anhydrase, thereby decreasing the breakdown and synthesis of bicarbonates, and they are used in glaucoma. And then aspirin, they inhibit the cyclooxygenase, thereby inhibiting the prostaglandin synthesis. They are used in as analgesic, anti-inflammatory drug. Disulfiram is competitive inhibitor of aldehyde dehydrogenase. Omeprazole is a non-competitive inhibitor of the proton pump, and thereby they are proton pump inhibitor, decreasing the gastric acidity. Digoxin is sodium channel inhibitor, sodium potassium ATPase pump inhibitor, used in CHF. And theophylline is phosphodiesterase inhibitor, thereby increasing the cyclic AMP level. Propylthiouracil is used in hyperthyroidism, where they inhibit the peroxidase enzyme, thereby synthesis of the thyroid hormones, thyroxine. Lovastatin is in HMG-CoA reductase non-competitive inhibitor, thereby inhibiting the cholesterol synthesis. And sildenafil is phosphodiesterase 5 inhibitor, and they are used in erectile dysfunction. So these are the different drugs which are the non-competitive inhibitors. So that was all about the enzymes and their inhibitors. Coming to the next side where the drug acts is the ion channels. So the common ion channels are proteins which act as ion selective channels. They participate in transmembrane signaling and regulate intracellular ionic composition. So these channels help in a balance of the ionic channels. So these are the drugs such as quinidine, which blocks myocardial sodium channels, dofetilide, amiodarone, they block the myocardial delayed rectifier potassium channel, or the nifedipine inhibits the calcium L type of voltage sensitive calcium channel. So all these drugs, they are used as antiarrhythmic drugs. Then we have the drug that is sulfonyl ureas, which are hypoglycemics and used in patients of diabetes mellitus. They act by inhibiting the ATP sensitive potassium channels, and they are used in patients of diabetes mellitus. Amiloride, they are the diuretic drugs. They inhibit the renal epithelial sodium channels, thereby increasing the sodium excretion and water excretion. Phenytoin, which modulates the neuronal sodium channels, they prolong the inactivation state, and thereby they are used in patients of seizures. And ethosuximide is also a drug for seizure. They inhibit the T type of calcium channel in the thalamic nucleus. So these drugs, they are going to modify the different types of ion channels in the body, and based on those changes or the modifications in the ion channels, they are going to produce the effect. So the first is the enzymes, second is the ion channels. Next in the line, we have the different types of transporters. So the transporters, they help in the transport of certain endogenous substances across the biological membranes, as I have told you earlier also. So that substrates are translocated by binding to the specific transporters or the carriers, and thus they pass through the biological membrane. So the desipramine and cocaine, they block the neuronal reuptake of noradrenaline by interacting with the norepinephrine transporters. So they will increase the synaptic level of the norepinephrine. Similar to this norepinephrine transporter is the fluoxetine or the selective serotonergic reuptake inhibitor. They inhibit the serotonin reuptake by inhibiting the serotonergic transporters. Similarly, amphetamine, they block the dopamine reuptake in the brain or the neurons by dopamine transporters. Others are the vesicular monoamine transporter inhibitor reserpine, which will block the vesicular reuptake of noradrenaline and serotonin inside the vesicle in the presynaptic neurons. And what they do, due to this inhibition by reserpine, the noradrenaline is metabolized and not stored in the vesicles. Similarly, hemicolonium blocks the choline uptake in the cholinergic neurons, and thereby the acetylcholine level will decrease. So all these, when you will be taught about the ANS, you will be taught about the synthesis, release of the adrenaline, noradrenaline. So you will be more clear with how these drugs are going to act. And tigabayine, they inhibit the reuptake of GABA in the brain neurons by GABA transporters. Similarly, the diuretics like furosemide, they inhibit the sodium potassium 2 chloride channel co-transporters in the ascending limb of loop of Henle. And the other diuretic like hydrochlorothiazide, they block the sodium chloride symport in the early DCP. So next is the receptor mediated action, and I think this I will start tomorrow. Thank you very much for your patient listening.